Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today I'm delighted to be joined by Sita Kapoor. She is a co-founder and CIO of HealthEC. Sita, thanks for joining me today.
Thank you, Nick. It is a pleasure to be with you on a beautiful day like this.
So for the benefit of the listeners, I always like to get a little bit of background about the individuals that I'm talking to. Share a little bit about your history, how you got here, what your sort of experiences are to get you to this point as CIO of HealthEC.
I'm a data scientist, mathematician by background. Started my career working for flight computers and satellite computers, and then joined the healthcare industry. For 20 plus years, I've been in healthcare, working in clearinghouses, working with data, and trying to get actionable events out of it.
So, first of all, really cool to be on with another space geek that has been deep in that domain. Tell us a little bit about the processing and your experiences in doing that has sort of led you to this path that is now healthcare, which, I meet the occasional person that's been in those industries, but not always. So how did you arrive at this point?
Sure. So started my career on flight computers and trying to manage the satellite telemetry data coming in from different satellites. Worked at the NASA also at one point. Most of that was collecting data, and some of it was in real time coming in as telemetries, and taking all of this data, analyzing it, and trying to make some insights into any anomalies that may be there with any of the flights or with the satellites, and then presenting it to business analysts so they could take an action or call the ground technical ops people to take an action to make sure the health of these satellites were good. So worked with data for all my life, and this is going back 20 plus years when you didn't have as much of technology, but even in those years it was data that drove me into coming into the healthcare. At that point in healthcare, it was paper forms. And we truly built an OCR, almost like an NLP you call today, to be able to take paper data and convert it into electronic data. So you could connect data from the providers to the payers and, create the first electronic data exchange between providers and payers.
So were you one of the original HIEs in that concept?
No, we were before HIEs. We were one of the original clearinghouses.
Wow, you predate HIEs.
Yes, I predate HIEs. We were the first clearinghouse. NEIC, if you're familiar with it, out of Secaucus, the 5 payers came together and created NEIC. And just to be clear,
this was still in the days of paper?
Yes.
Wow.
This was just getting off paper when we had the HEC for 1500s were just being finalized. 1450 were there. UB82s were there, moving to UB92s. This is pre-837s.
Wow. Think about that, folks. So if you want to talk to somebody that really understands integration of data going back a long way and understanding how difficult that is, we've got that individual right here. So as you think about where you are now, tell us a little bit about HealthEC and what it is that you brought to that organization and what you're doing there that sort of relates to this, and the flow of that. Because I don't think HealthEC was part of that. That was a different company in your past,
yes,
right? Yeah.
That was MedLink was a different company which was bought by WebMD, and it was part of EMD on. So we in the journey of data and healthcare, in the middle, we started working with big healthcare companies like United Health Group, Siemens, Johnson & Johnson, creating data marts and data sets for them. Eventually, we decided that, we wanted to go back and build our own company. And that's where we started IGI Health, which became HealthEC. So we had learned data, we knew data. We got back and started another clearinghouse, collecting claims data, beneficiary data, practice provider data, build that. Then the HIEs started to come in. I mean, we went through the CHINs and the RIOs also. So now the HIEs.
Wow.
and we were awarded the one of the grants in the state of New Jersey to build the HIE in the Newark with 8 hospitals. We layered over claims data, your ADT, admissions and discharge data, your ORUs, your lab results data into a data set. We became partners with LabCorp and started receiving lab data from them. At the same time, the MU was coming in and PQRS and EMRs were becoming electronic.
I'm just going to say, you've managed to kill more abbreviations in a single sentence almost that you've been involved in. That's just astounding. And I know what they all mean, so I'm just dating myself as well. But sorry, go on.
So we started working with EMRs to get EMR data from them. The proprietary files, but 10 years ago, it was still very proprietary, but right now I'm glad to say that we are seeing a little bit more standardization from the larger EMRs. So think about claims data overlaid with HIE data, overlaid with lab data, EMR data. Now we've got other data points like, your wearable devices or your SDOH data coming into it, or assessments that are being taken, all flow into the same data store. The whole system we built is ground up. So We did not buy any other companies, all architected and built by my team.
So tell us a little bit about the sort of components. What contributes to that as a sort of aggregation, and how do you? What's the lens that you look at that before you start to think about it in terms of the automated processing?
So when you look at the data, we look at it from different lenses. So if you're looking at claim data, you have object models that spindle on the claims, which is the payers and the provider.
Right.
Then you start looking at HIE data, and that is a spindle of an episodic, because it's all got to do with the episode and the episode of care. You look at the lab data, it's spindled on the lab data sets. So we created multiple, the HI and the EMR are on the episode. So we created multiple object models, the clinical data repository, the lab repository, the claims repository. But the thing that connected all of this for us were the 3 Ps. One is your plans or the payers. The second is your practice provider. And the third is your patient. Now we had to create the longitudinal view for the patient. So other people had the other spindles. The one that everyone struggled with to create a longitudinal view for the patient with all these data sets correctly aligned within it. And as we know, the largest challenge on creating the longitudinal record is creating the enterprise master patient index. We learned ground up. That's what they say. So we learned ground up. So we started building it like when we got a member file and a payer file and a claim files. How do you connect it to create a member ID that can get adjudicated best and not get rejected, or subscriber ID? And the different words you have for them, right? Member ID, subscriber ID, MRN ID, chart number. And as you go further on, they can be called different. So the goal was, how do we get these disparate data sets of patient information and create the EMPI? So we learned ground up. We built the algorithms way back. Initiate was one of them. We entered some challenges with them. A lot of people were into fuzzy logic and things. One of the things, because we grew up with healthcare, we grew up in the data sets, and we had very good clinicians, is you cannot misalign data. So our goal always was to ensure when we combine 4 or 5 data sets, the EMPI truly belongs, the health record key truly belongs to that particular patient. What we found very soon is that then you could end up with duplicates and things would not align properly. So we created programs and processes around it to be able to determine those that were duplicates and would send it back up to, say, the clients, whether it's an IDN or a payer or a self-funded, with the data saying, hey, these 2 appear to be the same, but the date of birth is different. They appear to be the same, but the gender is different, or, things of that. So we would create a feedback loop for them to merge the data and return it to us corrected. So if you would go back 10 years, we started off, I would say, at a 68% good match. I'd like to say we have learned and our algorithms have matured today to be almost at an 89% good match. To be 100%, if anyone tells you, Nick, they don't know healthcare.
No,
they've come from a different industry.
Even with the master patient index, that's just not the case. I mean, there's a number of countries that, have nominally a master patient index, and they still have problems matching. I know there's a lot of push here, and we should have one. Our social security is not it, to be clear, but that, ability to match. I think what's really interesting about this, and I think, from a quality data standpoint, it's so important to get the right data in. So, you're doing two things that I think are critical here. One is you're not putting together records that don't belong together, which would be a disaster from a clinical standpoint. And two, you're going back to the source. So sure, you could fix it. You can have people and, deal with that and even deal with it programmatically. But ultimately, if you don't fix it at the source, someone else is going to get that data, and it's amplification of the same information. So
Correct.
Obviously, key assets in that space. Tell us a little bit about the processing. So now you've got these multiple spindles, the payer, provider, patient. I think you talked a little bit about some additional ones, the value add of LabCorp. What are you doing now to sort of provide insight? So you've matched it all. You've got this fantastic resource. What are you delivering with that?
So after that, you have to do the data cleansing and the data transformation. Another key element that sometimes people forget to do is you have to dedupe the data. What I mean by that is you could get the same data sets from different places. And also you have to determine the source of truth for them. Or how do you prioritize which one is giving you the right clinical information? So now I'm getting to the clinical piece, right? If the pharma data tells me they're on metmorphin, but my EMR data says they're on warfarin, for example. So how do you mitigate that? So it's called, a lot of intelligence went into determining the data cleansing, whether it's diagnosis, whether it's meds, whether it's vitals, and to get the source of truth. So in the beginning, during implementation, we kind of put those layers in place because the data quality is extremely important for the next step, which is running business rule engines or care coordination on top of it.
Right.
So we spent a lot of time and energy and learned in the process and have a good handle on how do we get this data to be transformed so that we can explore it for machine learning and AI, which is, of course, where everybody is headed towards. So that is the data cleansing process. How do we use the data is a good thing. So to give you a few use case examples, the simplest one that everyone started with, hey, how do I find the top 5% that's costing me 45%? And get care coordination around them. These are the people that are using hospitalizations or medications and need the most care. How do we create programs for them? So our Care Connect platform, which was built by doctors and nurses, took everything they did manually and put it into a system where a care navigator can log in and they would get their panel they have to manage, plus they would know what are the interventions for today with each patient. Making it easier. And once they have completed the intervention, it would trigger another one. And all of these were dynamically actionable events. So you don't have to manually remember to call a person back. Based upon how you took care of them today and the data sets that we had, we could figure that out. The second use case is high ER utilization. So how do we get ADT data and start looking at those that are frequent flyers or that readmission was a very big thing. So how do we ensure we do the 7-day, 14-day program? And this we could provide real-time admissions and discharge notifications within the EMR or on a mobile device or on an email based upon how the workflow would be or within the Care Connect platform for them to take the action. The other very important piece that we provide is the quality measures, whether you call them MIPS or you call them quality measures, disease registries, care gaps, HEDIS measures, any one of those terms. They are basically rules for how do you better take care of people, whether they are preventive care, diabetic, cardio, immunization, child, behavioral health. All of those are running these rules and finding out what are the things that still need to be done. They need to have a eye exam and they need a foot exam. And they need their medication is not updated, and creating them into actionable interventions so that it becomes easier for someone who's managing the patient. Like when they call the patient, hey, you talked to them about these, but remember, please ask them about these 4 things also. So that makes a single call more meaningful at that point.
For those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to a fellow space geek, Sita Kapoor. She is the co-founder and CIO of HealthEC. We were just talking about use cases, the process of getting to this data, the importance of, cleansing, deduping, or getting rid of duplicates, the source of truth, which, one of those areas that, consistently causes problems in healthcare because we get multiple instances and, sometimes quite conflicting versions of, the same data. Has a diagnosis, doesn't have the diagnosis, drugs and so forth. So, huge challenges. But importantly, I think what you're doing is getting to the point of, this clean data set. And now, obviously, you've got the capacity to rank. So you were talking about the simple use cases of risk stratification, spending the best available amount of my personal time as a physician on the, the most important case where I can make the biggest difference. And I imagine that as a sort of concept must play extremely well, especially as I think about COVID-19 and the challenges that we're sort of faced in today.
Absolutely. So once the COVID-19, at beginning of March, we put a tag team together. Most of the risk stratifications you get there, Nick, are patient-related. Our goal was, how do you find patients who are going to be at risk for COVID-19 and identify them as fast as we could? So for the patient populations for our clients that we managed, we were able to run our algorithms and identify those patients that are at high risk for COVID-19. When they log on to our Care Connect, that panel came up. They could do a quick assessment. Based upon the assessment, we create another list of interventions that should be taken care of. So our goal was to provide these lists, have actions taken. Plus, we were getting the Johns Hopkins feed. We overlaid it with the patients that we were managing for our clients to find the hotspots and to quickly identify even those patients that we did not identify to be high risk for COVID would be high risk because they are in that hotspot area, and right. To create the next set of lists, hey, start calling those people. Because we were connected to multiple HIEs, in the country, and especially for our clients, we were getting the ADT information, plus we're getting lab information. We were able to correlate those two data sets also to now giving interventions and saying, hey, one of your patients has just been discharged. You need to take special care of them, or, they need more attention. So we were able to create these cohorts to manage. And we had a client in Jersey who is an oncology practice, and for them, they're very high risk just by being part of a cancer, a cohort. But within their practice, identified those that are at the highest risk for COVID. And the CMO over there called up and said, it is amazing. The panel you provided was absolutely right. You were able to identify all our people within 4 days. I think they did a big outreach. About 20 people called all their patients out, and they were able to put them at rest, tell them what to do, and were able to get interventions based upon their assessments that they did for them. So those are the type of programs, innovation that we try to bring to the industry.
So it's fascinating. So you take that risk stratification, obviously multiple pieces. I think the GIS data is sort of critical to this because, if you're in a rural area with, almost negligible instance of COVID-19, that dramatically drops, so, less important. And clearly, the integration of all of that, one of the things that physicians or anybody in this business can't do is process all that information in a meaningful way. They need that sort of, sort of filter. It's never a data problem. It's always a filter problem. And in this sense, it sounds like this is providing that sort of filter capability that really delivers value at the point of care. As we sort of close out the discussion, tell me what what the future holds. What is the opportunity? It feels like we're just taking little baby steps at this point. Now, maybe, in your fighter pilot days and, satellites, that they were way ahead. I'm guessing they were.
They were.
But we're behind. So there must be huge potential for this in terms of the capabilities. Tell us a little bit about that.
Yes, I believe there are huge potentials over here as we start to get good data sets in place, what we will be able to do very, very quickly is run machine learning and AI models on top of them to start to better understand this data and to give you better outcomes. For example, we were part of an AI challenge with CMS and were picked as the top 20 based upon the data they gave us, and we ran our algorithms to identify patients for unplanned readmissions, planned readmissions, as well as for in the hospital and SNF. So these are the type of innovations that we can do once we get these good data sets in place. It's very important also for us to create more innovations out of it. For example, on the cancer side, we are starting to pick up the biomarkers that come in from OmniSequence and the LabCorp and combine it with the physical vitals, all the clinical information to create therapeutical decision trees on what drugs will best suit them or what are the best clinical trials they can be part of. So this is all because of good data and machine learning that we all are starting to get a bigger set of people to work with. I do feel we do need to come closer as an industry. What I mean by that is data sharing has to become a second nature in healthcare. Right now, everybody is sitting and saying, this is my data, and this is my data, and this is what you can do and cannot do. For truly making an impact to us, we are all patients in one way or the other. We need to be able to give these to the right people who are going to be able to take it and provide interventions or provide care pathways that we don't have to go to a doctor. Before we go, we are told what we need to do to prevent it. So I believe that the Cure Act in place, the Blue Button, the interoperability discussions up at the legal places are very important for us to be successful in interoperability, to get the data that we need to provide the right interventions. As a technologist, I feel we have the technology solution. We just need the business rules and the economics to be put in place right now.
Yeah, I couldn't agree more. I think the importance of sharing of data and, mostly it's not a technical problem anymore. It's really, more an economic issue, sometimes a political issue. Data sharing is data caring, ultimately. And the more that we share this, obviously with the appropriate protections in place, I think, I just take that as a given. I know that's challenging with some of the data sets, but, essential because that sort of enables all of these tremendous capabilities that essentially are challenged because they don't have access to the data. So, if there was a resounding message, it's, sharing is caring in this case, and that's with data. So, as usual, unfortunately, we've run out of time. So it just remains for me to thank you, Sita, for joining me. It's been a fascinating conversation. I wish we'd had more time to dive into the space geekiness that is obviously one of my areas of passion, those folks that know me. But otherwise, truly insightful, and thank you for joining me.
Thank you very much, Nick, for this opportunity, and wish all the best to all the viewers.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.